All right, let's get into it. Today, we're really digging deep into something crucial for anyone interested in horses, really. Equine health and performance. We're talking about dynamic collapse of the upper airways. You've given us a rich stack of sources, from basic definitions right through to, well, some pretty intricate surgical procedures. And our mission in this deep dive is to sort of extract the most important nuggets of knowledge, help you understand why these conditions happen, how they're diagnosed, and crucially, what can be done to help these incredible athletes.
Yeah, it's a critical topic.
Yeah.
And you're right, it's complex. Fundamentally, we're looking at a group of disorders. They cause this transient obstruction to breathing. It happens in the pharynx or larynx, often cycling with inspiration, when they breathe in. A lot of it comes down to fatigue, basically. Fatigue of the muscles that normally keep that airway nice and open. And it becomes this kind of vicious cycle. The harder the horse tries to breathe,
The worse it gets.
exactly. The increased respiratory effort actually worsens the obstruction. It pulls those tired tissues further in.
That collapsing straw analogy you mentioned earlier really hits home. It sounds like the horse is almost fighting itself. So it's a group of disorders causing this temporary block in the pharynx or larynx.
That's right, primarily affecting the upper respiratory tract. But, and this is important, if it's severe or goes on for a long time, chronic cases can lead to secondary problems. We're talking cardiopulmonary changes, all because of those repeated high negative pressures inside the chest and the lack of oxygen, the hypoxia.
Wow, okay. And who does this affect most? Is it specific breeds or ages?
Well, it can affect any age or breed technically, but where we see it most commonly diagnosed is in racehorses, particularly young ones, those 2- or 3-year-old thoroughbreds.
Why them specifically? The intensity?
Precisely. The sheer effort. They generate these incredibly high negative inspiratory pressures during strenuous exercise. Pushes the system right to its limit. Oh, and also you see it in quarter horses with HYPP, hyperkalemic periodic paralysis. They can get severe obstruction during what they call paralytic episodes. It's a bit different, but related.
Right. The demands of the sport itself are a major factor. So for someone, watching a horse, a trainer, owner, just an enthusiast, what are the outward signs? What should they be looking or listening for?
Okay, key signs. First, exercise intolerance or just, poor performance. They just can't keep up. Then, the abnormal noise, usually during inspiration when breathing in, sometimes described as a roar or a whistle.
A roar.
Yeah. Though, there's one specific condition, dorsal displacement of the soft palate, DDSP, that actually causes expiratory noise, a kind of gurgle. That's the exception. You might also see coughing. And maybe surprisingly, dysphagia, difficulty swallowing.
Difficulty swallowing. How does that tie in?
Well, the mechanics back there are all interconnected. If things aren't working right for breathing, it can impact swallowing too.
Okay, that makes sense. Now, you mentioned roaring and gurgling. These sound like nicknames almost. So I'm guessing dynamic collapse isn't just one single thing. It's more like a range of specific conditions.
Exactly right. It's an umbrella term. There's a whole cast of characters under there, each with its own quirks.
Let's unpack the most famous one then, the roaring. What's actually happening inside when a horse roars?
Okay, so roaring is typically laryngeal hemiplegia, or roar. It's the most common one we see. Usually, almost always, it affects the left arytenoid cartilage. Think of these like curtains in the larynx that should open wide. In this case, the left curtain doesn't open properly. Or it even collapses inwards during inspiration.
And why the left side?
It comes down to nerve damage. Neurogenic atrophy of the muscle that pulls it open, the CAD muscle, cricoretinoideus dorsalis, damage to the nerve supplying it, the recurrent laryngeal nerve, and it's usually the left nerve that's affected because of its longer path through the chest. So when the horse breathes in hard, that cartilage fails to pull back, causing turbulence and that classic inspiratory roar or whistle. And of course, exercise intolerance.
Wow, that's specific. Damage to one tiny muscle on one side. Okay,
Yeah.
So then what about the gurgler, DDSP? What's the mechanism there?
DDSP dorsal displacement of the soft palate is different. Here, the soft palate, which normally sits underneath the epiglottis.
The little flap at the back.
Yeah, that flap. The soft palate actually moves up and over the epiglottis during exercise. It basically blocks the entrance to the larynx. And this causes that distinctive expiratory noise, the gurgle, or sometimes called choking up.
And what makes the palate do that?
It could be a few things. Neuromuscular dysfunction, maybe the signals aren't right, or the palate itself might be abnormal, too long, too short, too flaccid. Things like epiglottic entrapment, which we can talk about, or even just how the horse carries its head, high head carriage or simple fatigue during a race can trigger it. It can cause pretty sudden respiratory distress. Sometimes people say the horse swallowed its tongue, which kind of gives you an idea of the sensation.
Okay, so roaring and gurgling are the big two, but you said it's a whole family of conditions. What else is in there?
Yeah, there are others, definitely less common sometimes, but important. You can get epiglottic retroversion, where the epiglottis itself flips backwards, probably an issue with the hypoepiglottic muscle. Then there's dorsal pharyngeal collapse. This is where the walls of the pharynx itself, the throat, collapse inwards, weakness in those pharyngeal muscles. We also see epiglottic entrapment. That's where a fold of tissue, the aryepiglottic fold, kind of blankets the epiglottis, causes noise, and can actually predispose a horse to DDSP.
Ah, so they can be linked.
They can, yeah. And there's axial deviation of the aryepiglottic fold, similar tissue, but here the folds get sucked medially into the airway opening during inspiration. And lastly, things like subepiglottic cysts. These are fluid-filled sacs under the epiglottis. They can be congenital or acquired. They physically block things or push the palate out of place, potentially causing DDSP that way too.
Wow. That's quite a list. It sounds incredibly complex to figure out exactly which one or maybe even combination is affecting a particular horse. How do you even start?
You're right, it is complex, and getting an accurate diagnosis is absolutely crucial. You can't fix it if you don't know exactly what's broken. It's usually a multimodal approach. Always starts with a really detailed history, what's happening, when, what kind of work, and then a thorough clinical exam, listening carefully to the sounds, palpating the larynx externally, seeing if there's any obvious asymmetry or muscle loss.
What can you tell just by looking inside when the horse is standing still? With an endoscope, I mean.
Right, resting endoscopy, that's a vital part. We pass the scope up the nose. It lets us see the structures, check for obvious abnormalities like cysts or entrapment. We assess how the larynx and pharynx function during quiet breathing, maybe after we briefly block the nostrils to make them breathe harder, and importantly during swallowing. But, and this is a big but, its limitation is that many of these dynamic collapses only happen at high speed. The horse can look perfectly normal at rest.
So a clear resting scope doesn't mean everything's fine.
Not necessarily for performance issues, no. But we do look for clues. Like, if a horse displaces its soft palate really easily at rest, or struggles to reposition it after swallowing, that makes us suspicious of a pharyngeal problem during exercise. We also grade laryngeal function. A horse with grade 3 impairment, meaning it can't fully and symmetrically open those arytenoid cartilages after swallowing or nasal occlusion, that's considered significantly impaired for a racehorse. Though, interestingly, a show horse doing less intense work might cope fine with that grade.
Okay, so resting scope gives clues, but isn't the whole story. You need to see it happen under pressure. How do you manage that? The gold standard.
Exactly. The gold standard is dynamic endoscopy. This means scoping the horse while it's exercising at high speed. This can be done over ground, literally, riding the horse on a track with the scope in place or on a high-speed treadmill. This is crucial because it lets us see the airway function or dysfunction under the exact conditions that cause the problem.
Wow. Scoping a galloping horse, that must take some setup.
It does. And ensuring it's a valid test is key. You need to match the exercise intensity to what the horse actually does. Simulate head position because neck flexion matters. We often use a heart rate monitor, a Holter monitor, to make sure they're actually reaching maximal exertion, usually a heart rate around 220 beats per minute or more. And using a video endoscope is essential. You record everything, then play it back, often in slow motion, to really pinpoint what's collapsing, when, and how severely. For racehorses, sometimes you even need to simulate the stress of a race, maybe have another horse challenge them during the scope to trigger the issue.
That's incredible detail, like getting a live feed from inside during peak performance. Are there other diagnostic tools you might use alongside this?
Yes, sometimes other tools help fill in the picture. Ultrasonography can be really useful, especially for laryngeal hemiplegia. It lets us look at the laryngeal muscles themselves, assess for denervation, that muscle wasting we talked about. Radiography or X-rays can help identify things like subepiglottic cysts or any underlying bony issues. And occasionally, some specialists might use spectrogram analysis, that's basically analyzing the sound waves of the respiratory noise to help differentiate between different types of obstruction. It's quite technical.
Okay, so you've gone through this whole process, maybe even the dynamic scope, and you've pinpointed the issue. What does this mean for the horse? What are the solutions? Is it always surgery?
Right, the path forward. The main goal of any treatment is pretty straightforward. Create a stable, open airway that won't collapse under those high negative pressures during exercise. And, well, yes, often surgical intervention is required to achieve that reliably, especially for performance horses.
Let's talk about roaring again, the laryngeal hemiplegia. What's the main surgical fix for that?
The standard procedure is the laryngoplasty, often called a tieback. What we do is use a strong, non-absorbable suture to permanently pull back or abduct the paralyzed arytenoid cartilage, usually the left one. It basically props that side of the airway open.
A permanent prop. Does it work well?
The prognosis for return to performance is generally considered good to fair, maybe 50 to 80% success rate, depending on the study and the horse's job. But it's not without potential downsides. Complications can include things like chronic coughing or sometimes issues with swallowing that could lead to aspiration pneumonia, though that's less common with modern techniques. Sometimes they'll also do a ventriculectomy or ventricular cordectomy, removing small structures in the larynx to further improve airflow.
Okay. And for the gurgler, the DDSP, is it a similar tie-back idea or totally different?
It's a different approach for DDSP. Sometimes conservative management is tried first, things like tongue ties, different bits, throat support devices, changing head carriage through training, trying to manage it without surgery. But for surgery, one of the most effective options currently is the laryngeal tie forward. This is quite different from a tie back. It involves surgically moving the entire larynx slightly forward and upward relative to the palate. This increases the overlap between the epiglottis and the soft palate, making it much harder for the palate to displace dorsally, to flip up.
Ah, so you're stabilizing the relationship between the parts. What's the success rate like for that?
It's generally pretty good. Prognosis is often fair to good, maybe in the 60 to 80% success range for returning horses to their previous level of function. There are other surgeries for DDSP too, but the tie forward is quite common now.
It's really amazing how specific these surgeries are. What about those other conditions you mentioned, like the entrapped epiglottis or cysts? Quick insights on those.
Sure, epiglottic entrapment is usually treated by surgically cutting that entrapping fold, often with a laser through the endoscope. Prognosis there is typically good to excellent, maybe 80–90% success. Subepiglottic cysts are generally surgically removed, maybe lanced or excised. Again, prognosis is usually excellent, often over 90% success once the obstruction is gone. Now, conditions like pharyngeal collapse or axial deviation of the aryepiglottic folds, those can be trickier. The weakness is often more diffuse. Surgery is sometimes attempted, but the prognosis can be more guarded. Sometimes management involves just reducing the work intensity, changing head carriage, maybe trying a course of anti-inflammatory drugs during rest if there's inflammation involved.
This raises an important question then. With all these variables, what really determines the overall outcome for the horse? It's not just the surgery itself, is it?
Absolutely not. The overall prognosis varies hugely. It depends on the specific condition, definitely. How severe is it? Are there other airway issues happening at the same time? Concurrent problems. The chosen treatment obviously matters. And critically, what's the horse's job? The demands on a top-level racehorse are far greater than on a pleasure horse. But what really underpins success is early, accurate diagnosis. Getting that dynamic endoscopy done right is key, followed by the appropriate treatment, whether surgical or otherwise, and proper postoperative care and rehabilitation. It's a whole package.
Well, you've definitely gained a really in-depth understanding now of this complex world of equine upper airway collapse, from those intricate muscle issues, the dysfunctions, right through to the sophisticated diagnostics like dynamic endoscopy, seeing inside a running horse, and these very targeted surgical fixes. You're now incredibly well informed on, well, a really critical aspect of keeping these equine athletes healthy and performing their best.
It really makes you think, though. All this precision needed to diagnose and treat these subtle but critical respiratory issues in horses. How might understanding that translate? Could it, influence how we look at maybe more subtle respiratory challenges in other types of athletes, perhaps even human athletes?
That is something to chew on until our next deep dive. We really hope this has been an illuminating journey for you, and we look forward to helping you uncover more fascinating insights very soon.